Assalamu alaikum, jami'an. Thank you for inviting me for this presentation, and thank you for introduction. Today I will talk about hemophagocytic lymphohistiocytosis. Actually, it's difficult to present something at the end of any conference, but I will try to make it very brief and to the point. Thank you. That's we done. Is this working? Okay. We have a number of terminology related to this presentation. First one is hemophagocytic lymphohistiocytosis, or HLH. Primary HLH, secondary HLH, familial HLH, macrophage activation syndrome, cytokine release syndrome. Before I proceed, I have a question to the audience. Is the HLH clinically diagnosis or pathological diagnosis? Both? All agree? Okay, خلاص weird. Okay, we have a small case. This is a 6 years old girl present with emergency department with 2 weeks history of sore throat, fever, rash, lymphadenopathy, abdominal distension, abdominal pain, arrival with high temperature, palpable cervical lymphadenopathy, and splenomegaly. Family, they don't have any hematological disorder. CBC shows leukocytosis, as you see, anemia, severe thrombocytopenia. Actually, clinical diagnosis or the possibility of this presentation, either sepsis, acute leukemia, Burkitt lymphoma, or HLH with infectious mononucleosis. They proceed to have bone marrow, what you see in the picture. What you see, anyone can have an idea or description? You can see the big cell is histocyte, as you see. It's actually, they have large nucleoli with indistinct cytoplasm, so that endless cytoplasm. But inside that cell, you can see red blood cell and some platelet. It's actually partially digested, so that this indicates this patient has hemophagocytic activity. This is another picture. You can see eosinophil, maybe lymphocyte, and some digested cells. So that actually in the bone marrow they have clear phagocytosis. At that stage, they proceed to have more investigation and more workup, starting by estimating the ferritin level, which was elevated. Triglyceride and fibrinogen was normal. They sent for soluble CD25, which was elevated. At that stage, they investigate for viral infection. Actually, they reach to the diagnosis of HLH in base of hemophagocytosis, high ferritin, and also soluble 25, fever, and splenomegaly, and thrombocytopenia. So that this is a classical scenario for HLH. We'll go, has more information about HLH. HLH, they have another name, which is hemophagocytic syndrome. It's an uncommon disease. It's related to dysregulation of immune activity, or overregulation or overactivity. Actually, it has a high fatality rate. You can see that only 5% of primary HLH, they have survival during the first year. Currently, after introducing the regimen for therapy, still they have high mortality rate, which about 40%. Usually, this patient present with non-specific clinical presentation like fever, splenomegaly, and cytopenia. The disease may manifest as a coagulopathy and hypertriglyceridemia, hepatic dysfunction, hyperferritinemia, and a neurological syndrome. This is depend on the infiltration and the involvement of the multiple organ. It is related to inappropriate immune response, starting by dysfunction of natural killer and T cell activity, leading to hypercytokine anemia and result activation of macrophage. So that it is dysfunction of T cell, cytokines, and then the macrophage will be hyperactivated. Cytokine, there is a multiple type of cytokine, including interferon, interleukin, a number of interleukin, and tumor necrosis factor. This cytokine will lead to a classical feature of HLH, which includes cytopenia and fever. This graph just summarizes the condition of a normal response, which is starting by T cell and then activation of cells, including the macrophage. But actually in HLH, this dysregulation leading to hyperactivity of macrophage, including the interferon alpha. The predisposing factor for this condition is genetic condition, also infectious disease, including cytomegalovirus, and COVID-19 is one of the possibility of introducing the HLH. Malignancy is another possibility of risk factor, autoimmune disease, and some drug. We mentioned the trigger factor. We have two main categories for HLH, which is either primary or secondary. The primary or the familial type of HLH is around 1 every 100,000 children. But the patient usually presents with early infancy and adulthood, and syndrome may be triggered by infection. There is a number of genetic mutation or dysregulation that related to the primary HLH, include BRF1 and other implicated, MONC and cytotoxin, and another type of cytotoxin. That was the mutation related to granulocyte-dependent lymphocyte activity. Here we have another conditions or syndrome that may induce the HLH condition, include Gracile syndrome and Harmoniski-Bodlik syndrome, and also some other genetic mutation. It's likely other gene will continue to be added as a possibility or introducing or precipitating factor for HLH. Secondary HLH is related to infection, autoimmune disease, and malignancy. It happened to all group of age without preference for gender. Macrophage activating syndrome is a condition that happens in the background of autoimmune disease, so that it is a certain condition, but it's a need to have a presence of autoimmune disease. Some therapy that can trigger the HLH condition, including CAR T cell therapy and some anti-seizure syndrome medication like lamotrigine. Diagnostic criteria for HLH is the Histiocyte Society 2004, which is a revision for HLH guideline, HLH 94 guideline. This is the criteria, which include two main elements. The first element is molecular diagnosis, which we mentioned before, and another one is diagnostic criteria, which is 5 out of 8 criteria. You can see here the fever, splenomegaly, cytopenia, which include hemoglobin below 9, and platelet below 100, and neutropenia, and hypertriglyceridemia, hypofibrinogenemia, and triglyceride, fibrinogen, and the HLH activity or hemophagocytic activity in the bone marrow, spleen, and lymph node, and low or absence of natural killer cell activity, high ferritin, and soluble CD24. So that the bone marrow is one part of the diagnostic criteria, but not all the diagnostic criteria. Here you can see the percent of the presence of the clinical feature of HLH. You can see the fever is around 95% of the cases. Splenomegaly is 89% of the case. Bicytopenia, 92. Hypertriglyceridemia is 90. Hemophagocytosis is only 82%. So that, and ferritin is high and low natural killer activity, soluble CD25 elevation. You can see the hemophagocytosis is only 82%. So that negative hemophagocytosis in the bone marrow not mean this patient is not HLH. You can see also the soluble CD25 elevation is high sensitivity for the diagnosis of HLH. But the problem of this laboratory test, it will take some time because most likely will be as a send out test. So that hemophagocytosis is not pathognomic for HLH. This is a very important message. Some patients may only show hemophagocytosis later in the disease. So that maybe it's at initial presentation, we cannot find hemophagocytic activity. There is a supportive diagnostic approach, which is H-score. It has been provided by Histiocyte Society. It is kind of online calculation of HLH probability. So that you go to the link and you accumulate, you fill the forms, and you will have H-score and the probability of having HLH. We have another very important message here. Most of the case with HLH, they have a background of disease, so that you need to investigate the possibility or the predisposing factor or the underlying pathology that trigger the HLH condition. In children, we need to identify is this case is primary or secondary in base of mutational panel. Initial treatment, the initial treatment is generally the same, patient with a primary form or secondary. Infection is the most common trigger factor for secondary HLH, especially in children. Other virus like Epstein-Barr virus, bacteria and fungi and parasite is a possible triggering factor for HLH. The treatment should not be delayed waiting for molecular testing if patient meet diagnostic criteria for HLH, so that we can provide a primary diagnosis according to HLH criteria. The main therapy approach, including etoposide, dexamethasone, and a certain protocol. Familial HLH is rapidly fatal if untreated, as we mentioned before. There is some therapy or targeted therapy that has been introduced recently. It's actually a monoclonal antibody against interferon gamma. This targeted therapy have been approved by FDA for a refractory condition and the primary HLH. Here you can see how this monoclonal antibody is targeting interferon to cut the process of activating of macrophage, so that it will limit the activity of macrophage. This is the therapy that used as a targeted therapy against interferon. This is the approval process for this therapy. Also, siblings with HLH match donor are recommended to screen for genetic before they donate the stem cell. Here the key point for this presentation: HLH remains complex multifactorial disease, relatively rare. It's possible under-recognized. It needs high level of clinical suspicion from the beginning. Actually, is a clinical diagnosis, but the support of the lab and the collaboration between the lab, I mean the clinician and the hematopathologist, is needed. Also, we need to investigate for the precipitating factor or the background disease, which could be autoimmune disease or malignancy, or the primary related to mutation. Some tests may take a long time, like soluble CD25, so that is a need not to delay the diagnosis. It's a life-threatening disease. Here I can summarize. A diagnosis of HLH is a critical step toward a successful therapy, but actually it is a rare disease, fatal, variable presentation, non-specific finding, a background of other disease. But practical consideration for the diagnosis is essential, and effective communication between the clinician and the pathologist is essential for diagnosis, especially patient with a critical condition. This is my reference. Thank you.